Thank you very much, Bill. I think this is a great idea, and we hope to not only have an educational forum, but a forum that we can actually have a little fun with. I have to congratulate the program committee for putting together really a true blue ribbon panel, and following the advice of our president, it's been very well globalized. Working from my far left this way, David Adams from Medical University of South Carolina in Charleston, Richard Schulick from Johns Hopkins, Rowan Park from the Royal Infirmary in Edinburgh, Carlos Chan from the National Institute of Mexico City, and Mike Farnell from the Mayo Clinic in Rochester, Minnesota. So I can't imagine that we couldn't have a better panel up there, but your vote, your input will count as well. Before we start, everyone is asked to take your panel. Their first question up on the board is we're going to try to distinguish who's a panelist and who's the audience. What I'm going to do with this is I'm going to tell you about the patient. We'll give you some x-rays to look at. Then we'll have you answer some questions with the vote pad. And then I may ask the experts to give their opinions before we reveal. But this will allow us to key in who's a panelist and who's part of the audience. So panelists, you vote A, and the rest of you please vote B. And we'll start the first case. Just to wait a few seconds. Okay, so if I can have my first slide. Okay, so this is a 52-year-old male who's actually transferred to your hospital, inpatient to inpatient transfer with acute pancreatitis. A little bit of the history is about a 3 to 4 week history of mild epigastric discomfort, but got worse over the last 3 or 4 days and associated with nausea and vomiting, which made him present to the local emergency room. And at least in Indiana, that means transfer to Indianapolis. The patient denies any previous episodes. He has no medications, no allergies. He has not drank alcohol for over 15 years, but he's a heavy smoker. He's also lost about 15 pounds of weight, but it's almost all been associated with this acute illness. The admission laboratory and physical examination, he's afebrile, vital signs are stable, has diffuse abdominal tenderness without any peritoneal signs. The lab work you can see there, amylase, lipase elevated, white count 15,000, his metabolic panel is normal. The plan that you brought forth was that you're going to admit the patient. The patient will be nothing by mouth, start him on IV fluids, and you obtain a CT scan. I'm going to work through a series of scans here. I guess I'll let the experts interpret it a little bit as we move through. Just a series, I will work a little quickly here. You can see there's some edema and stranding in the tail of the pancreas. As we move down a little further, you can see there's some peripancreatic fluid collections, a little bit of edema of the rest of the gland. We move downward. So what do we see? Basically, some focal non-enhancement of the pancreas in the region of the body and tail, a little bit of something suggesting pancreatic necrosis, a little fluid collection, and typical for a radiologist, they have disease but cannot exclude other diseases. So again, the next question I would have, the patient improves symptomatically, his white count goes down, he never has a fever, and in 3 days he's back on a diet and anxious to go home. So as the patient's going home, the question comes up, what do you want to do in follow-up? So here's our first vote. So if we could put the next the slide up. So the patient lives about 2 hours away. Do you want to just send the patient back to his referring physician? Do you want him to come back and see you in about a month? Or are you going to propose some sort of operative management based on the findings and the course? So please do the vote. Good tunes, anyway. All right, let me turn this. I guess we'll start at the far end with David because he certainly sees his share of pancreatitis patients. What would be your plans with this patient?
None of the above. So I think one thing you got to do in this patient is get an ultrasound before he goes. Make sure he doesn't have gallstones. Worry about that. And then I'd see him in follow-up and get the CT scan, but you need at some point to find an etiology for his pancreatitis,
Right.
whether that's ultrasound or even ERCP eventually.
He received an ultrasound, and it showed no gallstones. Rowan, obviously coming from Scotland, you probably wouldn't believe that he hadn't drank in 15 years. But
yeah, we need to go into that very carefully, but he absolutely needs a follow-up CT scan, and whether that's done back at the host institution where he's come from locally and the image is sent, or whether physically he comes back to your institution, doesn't matter, definitely needs a follow-up CT scan.
Okay, so could we see the results of how the group voted, assuming that Dr. Adams' suggestion for an ultrasound was obtained? All right, so pretty simple. I guess I've not made this controversial enough. So hopefully we'll push us a little bit. 100%, at least if you on the far end of the room can see over there, 100% of people wanted to see this patient back in a month. Oh, we got some late votes. It's Florida. We have to remember there may be some hanging chads that we have to follow up with. All right, so he comes back to see you in a month, and he's not perfect, but he's okay. He's certainly not having the same degree of pain that he's had. He's had no fever. He's eating, but again, he doesn't have much of an appetite. And as you requested, you get another CT scan. Again, I'll work through a series of films. So again, a lot of poorly perfused tail of the pancreas, and I can go back if anybody wants to see anything, but it really non-enhancement with a little bit of dilatation of the pancreatic duct, still a smaller fluid collection, but it's less. There's certainly less signs of acute pancreatitis, but there's still some suggestion that this is resolving. But again, our radiologists say disease cannot rule out disease, and do recommend a follow-up study with an endoscopic ultrasound. Of course, we don't always do what our radiologists say, so could we have the next decision that needs to be made? So what would be everybody's next step? Would you want to get an endoscopic ultrasound? Would you continue to follow this patient, or is it now time for an operation? So let's go ahead and have our vote again, please. Okay, Richard, what are you going to do with this patient now?
I think it's reasonable that there were no major changes between the two scans to bring him back in a couple of months for a repeat CT scan. You know, it's rare that you have a neoplastic process or a malignant process in this situation, but I think you have to keep that in the back of your mind. And sometimes we do have to heed the radiologist's recommendation.
All right, well, which one of our panelists, these guys won't, I won't protect these guys at all, so which one of you wants to operate right now? Mike Farnell. Why, Mike?
Excuse me. Sorry.
Hey, that was me, Mike. You're stealing.
Yeah. We didn't see the entire CT scan on the two that you gave us, but what we could see of the body and the neck of the pancreas, it looked pretty normal. This is extremely focal. Moreover, the pancreatic duct was very dilated in the tail. I'm very concerned about a neoplastic stricture of the pancreatic duct. The other thing I was going to ask is, do you have a CA19-9 to share with us in this patient's laboratory data? If I had that and it was elevated, coupled with the images I'm seeing, coupled with his weight loss, I'd offer this patient an operation.
Well, let's just say that you didn't get a CA19-9 when he was in the hospital. He's in your clinic now, just came up from the CT scan, and you're going to check on the box to